Guidelines on abdominal wall incision closure. European Hernia Society recommendations explained. Welcome to today's podcast, where we will be reviewing the key recommendations from the European Hernia Society on the closure of abdominal wall incisions. These guidelines are based on their most recent and comprehensive publication. Let us begin by establishing the core principle that drives these recommendations. The primary goal in closing an abdominal wall incision is to prevent incisional hernia, which remains one of the most common long-term complications following abdominal surgery. According to the guidelines, both the technique and the material used for closure are critical factors that can be controlled by the surgeon to reduce risk. Let us first consider the most common type of incision, the midline laparotomy. For this incision, the European Hernia Society strongly recommends the use of continuous suturing. Specifically, the guidelines advise the small tissue bites technique, which involves capturing between 5 and 8 mm of tissue from the wound edge, with each suture placed 4 to 5 mm apart. This method has been shown to significantly reduce the risk of incisional hernia compared to the traditional technique of taking larger bites. Another important aspect to keep in mind is the suture length to wound length ratio. The recommendation is to ensure a ratio of at least 4:1. This means that the suture used should be at least 4 times as long as the wound itself, which helps to secure the closure without placing undue tension on the tissues. Turning now to the choice of suture material, the guidelines favor slow absorbable monofilament sutures, such as polydioxanone or poly-4-hydroxybutyrate. These materials are preferred because they maintain their tensile strength for a sufficient amount of time, typically between 6 and 8 weeks, allowing the fascial wound to gain the necessary strength for healing. At the same time, they fully absorb after their purpose is served, thus reducing the likelihood of long-term complications like suture sinus formation or chronic pain. Next, let us address closure techniques. The Society recommends a mass closure approach, which means including the fascia, muscle, and peritoneum in a single layer with the continuous suture. This method is both efficient and provides excellent strength when compared to closing these layers separately. For other types of incisions, such as transverse incisions, the risk of hernia is inherently lower. These can be closed using either a continuous or interrupted technique, with slow absorbable suture material. When it comes to laparoscopic port sites, any site that is 10 mm or larger should have a mandatory fascial closure to prevent port site herniation. For smaller sites, those less than 10 mm, fascial closure is generally not required, although a small risk still remains. It is important to recognize patient-specific risk factors, such as obesity, chronic obstructive pulmonary disease, aortic aneurysm, or a history of hernia. While these factors should influence the closure approach, the guidelines emphasize that the cornerstone of hernia prevention lies in the closure technique itself, that is, the use of small bites, the correct suture to wound length ratio, and the appropriate choice of suture material. Let us also mention a few practices that the guidelines advise against. The use of large bites, meaning bites greater than 1 cm, is associated with increased rates of tissue ischemia and hernia. Rapidly absorbable sutures, such as those made from polyglactin, tend to lose their strength too quickly and result in a higher rate of hernias. Likewise, non-absorbable sutures, such as those made from polypropylene, are not recommended for routine closure due to higher rates of chronic pain and suture sinus formation, though they may have a role in select high-risk cases for experienced surgeons. For midline incisions, interrupted sutures are not advised. The continuous suturing method using small bites remains superior. In summary, the European Hernia Society offers a clear and evidence-based protocol for minimizing the risk of incisional hernia. Their mantra can be distilled as follows. For a midline laparotomy, employ a continuous suture technique using small bites of slow absorbable monofilament suture, and ensure the suture length is at least 4 times the wound length. Please remember that this is a summary intended for informational purposes. For complete details and clinical decision-making, always refer to the full, official guidelines of the European Hernia Society. The principal source for this discussion is the Society's paper titled, European Hernia Society Guidelines on the Closure of Abdominal Wall Incisions, published in the journal Hernia in 2015. Thank you for joining the Everything Surgery podcast. Dissect the extraordinary.